Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Fowden. I'm the chair and organizer of Grand Rounds. I am delighted that we're back today and with an invited speaker. This is Professor Sharon Pfleger. She is a consultant in pharmaceutical public health in NHS Highland, and she gave us the intriguing title of Finding Nemo: How Healthcare is Making Him Harder to Find, which certainly conjures up some ideas of what we're going to be talking about today. But I've had a sneak preview of the slides, and she's going to talk about water quality and how healthcare impacts on that, and what we can do about it. This turns out to be a subject close to my family's hearts, as my father worked for what was the National Rivers Authority and then the Environment Agency for the last 30 years. Until his retirement. So I know a little bit about river quality, and in fact even did my work experience sampling the quality of water when I was 14. I remember dipping bottles into the river air. So I'm going to get a big update on that from 30 years ago, and I just like to thank Sharon for giving the time to come and speak today. Looking forward to the talk. If you have any questions from the audience, please put them in the chat box. We'll get to them at the end, or you can raise your hand at the end, and if you're brave, you can turn on your camera. Sharon, thank you very much for coming. It's all yours.
Thank you so much, Tom. I'm delighted to be here to speak to the Grand Round today. And I'm just hoping that I'm fighting off a chest infection, so just hoping that my voice holds out for you. So do excuse me if I have to cough or drink during it. So yes, Finding Nemo, how healthcare is making him harder to find. So today I'm going to tell you about why water pollution is important in the climate change scenario, how healthcare we are contributing to it, some of the science behind it, some of the so what does it all mean, and then tell you about some work that I'm doing to reduce pollution, and finish off with some top tips for you. So by the end of the lecture today, you should understand the place of water in climate change and the environmental impact of medicines right across their life cycle. You should have enough knowledge to actually go out and tell your colleagues about it and recognise the practical steps that you can take to manage the environmental impact of your own prescribing. So the triple planetary crisis. Well, last year we saw COP26 in Glasgow, IPCC reports being published predicting global temperature rises. And it seems as if everywhere we turn, we talk about net zero. But climate change is actually just one part of that triple planetary crisis, which refers to the three main interlinked issues that humanity currently faces. And that's climate, biodiversity loss, and pollution. And the common thread that runs through that triple crisis is actually unsustainable production and consumption, which is having a devastating impact on our natural world, propelling climate change, destroying nature, and raising our pollution levels. Now, the Hippocratic Oath that we all work to, first do no harm, I would question whether it's actually fit for purpose in the face of impending planetary destruction that we face now, because a healthy population is actually dependent on a healthy planet. We can't have one without the other. So it may be time to rethink that oath, especially in the face of the statistics you see there below, where globally healthcare is contributing 2 gigatons of carbon dioxide into the atmosphere. It totals about 4.5% of the global net carbon emissions. And if we turned healthcare into a country, it would actually be the 5th largest emitter in the world. Or it's just like burning 514 coal-fired power stations 24/7. And right at the bottom there, you can see that medicines actually contribute about 25% of our carbon footprint. And I'll tell you today that they contribute a lot more than carbon footprint. Now, if we look at this ecological donut, we can see that the dark green bits, the ecological ceiling and the social foundation, are really, really important. Within that is the green space, where it's a just and safe space for humanity. And if we start eating into either of those dark green circles, we start to see an unjust space for humanity. We start to see society falling apart. So it's really important that we have an equilibrium of all the things that are important to keep humanity alive. And today I'm going to focus on the top right-hand corner of climate change, ocean acidification, and chemical pollution. Excuse me. So I want to start with some simple maths, because climate change actually is simple maths. And what goes into our atmosphere has to be removed. And achieving net zero, reducing our carbon emissions, helps that a bit. But we actually also need to produce oxygen for us to breathe and live. And we have to remove carbon dioxide as well. So a little known fact, maybe the title of this slide, is that actually all life on Earth depends on plankton in our seas. Excuse me. Our marine plants actually produce more than 90% of the global oxygen. And plankton remove most of our carbon dioxide, actually much more than all the forests and jungles in the world put together. However, 50% of our plankton have already been lost to chemical pollution, and they continue to die at a rate of 1% every year. So biodiversity is being lost, and it's being blamed on climate change. Excuse me. However, if you think about increased temperatures and more carbon dioxide, we should actually be feeding nature and resulting in growth. But what we're seeing is nature dying, and that is due to pollution by chemicals. And many chemicals are lipophilic, meaning that they behave like oils. So they don't dissolve in water, but they become adsorbed onto the microplastic particles that are in our oceans, and that actually concentrates them. And these particles then get eaten by planktonic animals or directly absorbed into the cells and plants, and this causes their death. Now, I'd like to talk a little bit about the science behind all of this, first of all, and think about water vapour. And 71% of our Earth is actually covered by ocean. And the main greenhouse gas, believe it or not, is water vapour, which contributes 75%. And again, thinking about net zero, we might think that the main greenhouse gas is carbon dioxide, but no, it's not. And the concentration of water vapour, excuse me, I knew this would happen today. The concentration of water vapour is actually regulated by air temperature. Warmer conditions mean higher evaporation from the ocean and a higher concentration of water vapour in the air. And this is known as the Clausius-Kiplion relationship. And it's a bit of a reinforcing feedback loop, because as the atmosphere warms up and the oceans warm up, there is more evaporation, and that leads to further warming in the atmosphere. Excuse me. Now, I'd like to now focus on the surface microlayer, the SML of the ocean. And it's between about 1 and 1,000 micrometers deep. And it's made up of proteins, carbohydrates, and lipids, but very importantly also surfactants that get produced by our phytoplankton. It's a living biofilm of bacteria and nanoplankton. So why is the SML important? Well, we know that the concentration of water vapour in the atmosphere is actually increasing, and we also know that the water vapour coming from our land is decreasing, which means that almost 100% of water vapour concentration in the atmosphere is coming from our ocean. And the SML actually reduces the escape of water molecules from the ocean, so therefore it also slows the transfer of heat into the atmosphere. So it's really important that it stays intact to prevent that heat and water coming out. But it's actually really important for ocean acidification as well. And in my mind, this really is the forgotten piece of that carbon jigsaw that everybody talks about when they think about net zero. The SML actually attracts toxic lipophilic chemicals, microplastics, and hydrophobic black carbon soot, which is the result of burning fossil fuels. And in that SML, concentrations of these toxic things are 500 times higher than they are in the water below. And they are toxic to plankton. So remember that I said plankton produced the surfactants. Well, if we have reduced phytoplankton growth, we have a degraded SML. We then reduce the capability of the plankton to assimilate carbon for us. We have a higher concentration of carbon dioxide actually dissolving in the ocean's surface. And that leads to a decline in ocean pH and ultimately ocean acidification. So, as I said, plankton actually absorb carbon dioxide. And if we lose them, then the excess carbon dioxide that dissolves in water makes it less alkaline and more acidic. And this means that any life that we have in the ocean that is based on carbonate actually begins to dissolve. And meeting net zero targets will not halt this. So if we start to lose the marine ecosystem, we lose our fish, we can't find Nemo, we lose our whales and our seals, and we also start to lose our terrestrial system. So put really simply, if plankton go, humans will go. And when the trophic cascade, or the destruction of the ocean, actually starts, it will happen very quickly over a 2 to 3 year period. And modelling currently shows that this is on course for 2045. And we can't stop this by focusing on net zero alone. This is down to chemical pollution. But we do have time to affect change, and we do have an opportunity to reverse this. So this graph actually shows how carbonate-based marine life is decreasing. And if we look at the blue line here, we can see that in 1950, we were at 100% population of our plankton, our fish, our whales, and other carbonate-based life. And you can see as we go through the decades, the red line, our pH of our ocean is falling constantly. The current position that we're at is this green circle in the middle, where we've lost 50% of all marine life. And when we get to 2045 and the pH drops to this level on the red line, this is what we call the tipping point, or the point of no return for our carbonate-based life. So it has started to dissolve, and it can't come back to life. And then you can also see the yellow line here. And when we get to that tipping point, we get bacteria and toxic phytoplankton actually starting to proliferate, and it will make our atmosphere much more toxic. So that was SML and ocean acidification. So what has SML got to do with climate change? Well, again, if we decrease the surface of our ocean, the SML, we get more evaporation of that water vapor, atmospheric concentrations rise. But we also have fewer aerosols, and that leads to more cloud formation and more precipitation. And if you've ever been on holiday to a tropical place like the Caribbean or Mexico or South America, you'll know that it's got a very high humidity as well as a high temperature, and how uncomfortable that feels. But you'll also know that the rain, when it falls there, comes in torrential downpours, and because the land is so dry, it causes flooding because the water isn't absorbed into it. So we can see that the ocean is almost entirely responsible for climate change that is going on in our world. And yes, carbon emissions contribute, but the ocean plays the big part in it. So what on earth has this got to do with healthcare? Well, I've talked about pollution already, chemical pollution, and medicines, pharmaceuticals, are also chemicals and are also polluting our ocean. And we know that the prescription of a medicine is now the most common thing that we do in the NHS, whether we use them to diagnose, cure, treat, or prevent disease. And in Scotland, we're spending just shy of about £2 billion a year on medicines. And a little known fact is that about 50% of the medicines that we prescribe don't actually get taken at all, or don't get taken properly. So we're not getting the clinical outcomes from that £2 billion of spend that we would be thinking we would be. So to keep that at the back of your head as well. So essentially, about almost £1 billion worth of medicines is going to waste. And we know that the use of medicines is increasing. So we've got a bigger population, we've got more older people, more polypharmacy. Once we get on that polypharmacy roundabout, it's really hard to get off it. We've got newer medicines, but we've also got a culture these days that tends to be a pill for every ill. So people turn to medicine to help them instead of, first of all, turning to things that they might be able to do themselves, like exercise or a healthy diet or meditation, for instance, to help their mental health. And we do know that because of the use of pharmaceuticals, waste and pollution is absolutely increasing. So how do medicines actually get into our environment? Well, for humans and animals, every time you take a dose of medicine, between about 30 to 100% of it comes out in our pee and our poo, straight down the toilet and into the wastewater system. And about 90% of the human medicines that we find in the environment come from patients actually using medicines. About 5% come from people flushing medicines down the toilet or sink because they think it's the safest thing to do. And about 5% comes from the pharmaceutical industry processes. But why is having medicines in the environment a problem? Well, it's because the wastewater treatment plants that they end up in were never designed to remove small, complex chemical molecules. The removal efficacy of wastewater treatment plants lies between 0 and 100%, depending on the medicine, depending on the rainfall that we've had. So inevitably, the water that comes out of the wastewater process, the effluent, actually contains small amounts of medicines. And these then get pumped into the rivers and oceans. And as well as the water effluent that comes out, there's also a byproduct of the process, which is sludge. And it also contains pharmaceuticals, but it's very commonly used to spread on our crops. So our crops then have pharmaceuticals in them as they grow too, and it enters our food chain. Whoops, I seem to have just lost my screen share, so let me get that back again. Righty-ho. Can anyone, Tom, could you tell me if you can see my slide, because I can't see my slide here.
We can see your the deck of slides.
Okie dokie. Let's see where I was at then and see if I can come to this one. Slideshow. Sorry about this. Oh, no, I don't want to do that. Let me work through these slides. Can you see the slides going through now?
Yeah, we can see you flicking through.
That's great. Thank you. Okay, so we were talking about how medicines get into the environment and that they ultimately end up in our soil and in our water. So let's now have a look at some of the evidence that we have accumulated since 1956, believe it or not. This slide is from a meta-analysis by Austerbeek et al., and it's showing that over 600 pharmaceuticals or their transformation products have actually been found in sewage, wastewater effluent, influent, and sludge across the world. And you can see that the highest numbers, the darkest colours on the slide, tend to be found in high-income countries. And the grey areas were the countries that didn't have any data to provide at the point of this study. We've since then had a newer study by Wilkeson-Boxall et al., which has just been published earlier this year. And in this one, they sampled 258 rivers across 104 countries, covering every continent in the world. And they analysed the samples for 61 pharmaceuticals. And in over a quarter of the rivers, they found that the concentrations they found were considered to be a threat to human health. And excuse me, the drugs found in the highest concentrations were painkillers, antibiotics, and anticonvulsants. Now, interestingly, in this study, the highest concentrations were actually found in lower to middle income countries. And the authors actually hypothesized that socioeconomics is involved in pollution, that these countries actually have access to medicines nowadays, but they don't have wastewater systems that are well developed. Hence, more of the medicines may be found in the rivers. And from our perspective as healthcare professionals using medicines, we get nearly all of our medicines from lower income countries. For instance, 95% of our antimicrobials are made in India. And the factories over there don't have as good husbandry as we would have in our own factories in Europe. So again, the medicines are being made and polluting the water environment around them. So this really is an example of inequalities at play in pollution terms. So we've seen that it's a global issue. So now let's have a little look at Scotland. Well, this slide is actually comparing the River Almond in Edinburgh with the Orkney Isles. So comparing and contrasting urban and rural populations, different population densities, different industries. And you can see here in a range of lochs, seawater and rivers that we again see a range of painkillers, antibiotics, oncology medicines and heart medicines found in the water. And even in my own patch in NHS Highland, if we go right to the furthest reaches of Highland, a really small coastal town, again, we can see commonly prescribed medicines are coming out in the wastewater effluent. And remember, that's the water that has already been treated. So they're ending up again in our rivers and oceans. So we know that pharmaceutical pollution is a global and a Scottish issue. So let's have a look at some of the evidence for commonly prescribed medicines. The one at the top of the screen here is 17-ethinyl estradiol, EE2, which we use in our contraceptive pills and our HRT products. Ethinyl estradiol has been found to feminize fish, and that means that the testes of the male fish actually contain eggs. And it doesn't need a scientist to tell you that that's not good for reproduction if you have eggs in your testes. So eventually this leads to population collapse from the feminization of the male fish. And that has consequences right up and down the food chain. Moving on to fluoxetine in the middle there, that's Prozac, one of our commonest antidepressants. And again, it delays the development of tadpoles. And at the bottom there, ciprofloxacin, a commonly prescribed antibiotic, inhibits the growth of duckweed. And you might think, well, so what? These are animals, they're not humans. It's weed. It doesn't matter. But actually, it's part of the overall food chain. And remember that we're right at the top of that food chain. So the minute you take something out in that chain, the rest of the chain actually suffers. So the studies that I've talked about so far have actually found that painkillers are one of the commonest classes of drugs that are found. So I'm going to give you some info on some of our most commonly prescribed painkillers now. Paracetamol is one of the most commonly prescribed drugs in the world. It's been found in waters right across the world and even found in drinking waters in some locations. It's now labelled as a priority drug because it's considered to have significant ecological hazard potential. And it actually amplifies the toxicity of other drugs as well. And along with that, after it degrades, certain of its photolysis products may actually be more toxic than the parent paracetamol itself. So that further complicates that environmental impact. Excuse me. It has been found to be acutely toxic to nearly all species of aquatic life, but it's specifically neurotoxic to freshwater shrimp and planarians. And these animals are really important because they're in the food chain as well, crucial elements, but they're also filter feeders. So they do accumulate higher levels of environmental pollutants, including microplastics. And if you remember, I said that microplastics actually absorb chemicals, including pharmaceuticals, onto them. So they have a very much concentrated number of pharmaceuticals in their gullets. And that's been found as close as St Andrews Bay and some research that's been done on shrimp there. Looking at ibuprofen now, again, we can see impacts on reproduction, cardiac function, and iron transportation in our zebrafish. And moving on to diclofenac and chronic exposure this time, so measuring it over a period of 28 days, which is more like normal aquatic life. This has resulted in various ultrastructural and physiological changes in a range of organs, from changes in metabolism to glycogen storage, kidney failure, and necrosis of the gills, which ultimately is fish death. So, so far, I've told you a bit about the evidence for behavioural, physiological, and reproductive changes in aquatic environment. But recently, many more studies are now coming up raising health concerns amongst susceptible human populations. For instance, our infants, the very ill, and our pregnant women and immunocompromised people. But the biggest concern of all from pharmaceutical pollution is actually driving the acceleration of antimicrobial resistance. And that's not just from antimicrobial drugs going into the ocean and rivers, because other drugs, normal run-of-the-mill drugs, can actually accelerate AMR as well. And I'd like to just spend a couple of minutes thinking about AMR. It is a global public health concern. It's called the silent pandemic, but I refer to it as pandemic plus, actually, because the death toll that is projected of 10 million people dying worldwide every year by 2050 is magnitudes above what COVID has done in the last 2 years, which is around 5 million in 2 years. And we know that every part of our health system actually depends on antibiotics, whether that's to treat or prevent infections. And if we think of surgery, one often gets an antibiotic before or during surgery, but we're running out of antibiotics that are not resistant. And this means we may not have any to use in the future whenever we need them. And this has the opportunity of making our routine operations like C-sections, hip replacements, or even giving chemotherapy much more dangerous. Maybe not even safe enough to be carried out at all, or if they can be carried out, they're just much more life-threatening, and they will mean much more prolonged stays in hospital for our patients. The pipeline of new antibiotics is near to empty, so it's really vital that we keep the ones that we have working for generations to come. And that means preventing the development of further AMR. So that's through health protection, through antimicrobial stewardship, but also through environmental pollution as well. So let's just have a quick recap so far of where we are on the evidence. So we know that medicines are made to have a biological effect, and they have that same biological effect in aquatic matrices as well. We know they're toxic and they harm our aquatic life, but they're also accumulating in aquatic life, and they're accumulating in our crops, in our food chain. And depending on their biodegradability, they can persist for a long time. And it's hard to get them out of the water. And we know that the vast majority that we use don't actually have environmental risk assessments associated with them. So we don't really know what they're doing to our environment yet. So this is what I call a wicked problem. And just like COVID, no one organisation or country can actually solve this on their own. It needs us to work together in partnership. We need to work upstream. We need to try and fix the problem before it actually reaches the water, because once it does, it's incredibly difficult to remove pharmaceuticals. And as the evidence of harm to human life is actually building, I would suggest that we work on the precautionary principle, that we have not got time to wait. And certainly in terms of ocean acidification, we certainly haven't got time to wait. So we recognised this in Highland about 4 years ago, and that's exactly what we've done. We've developed or formed the One Health Breakthrough Partnership, and you can see the companies, the organisations along the bottom there that are involved. We think it's a world first. It's a unique collaboration with 3 public agencies and 2 higher education institutes actually working together and sharing the knowledge and the data that we have. And we've all got different parts of the jigsaw, so it's really fantastic to see what we can do together. And in the Highlands, just like the rest of Scotland, we've got a lot of water, and we all, as people in the population, actually benefit from social capital that water brings us, whether that's tourism, food and drink production, or just opportunities to actually live healthy lives in nature. So our vision is for a non-toxic environment, and we want to improve healthcare, drive research and legislation forward with the innovation that we are currently finding. And I think it's really helpful to think of a pharmaceutical or a medicine in terms of its life cycle. And that's what we're working to in the One Health Breakthrough Partnership, because the further along you get to that right-hand side, the pink wastewater, the harder it is to do anything about it. And the more the problem has already started and can't be fixed. So if we get to the left-hand side, we're working upstream, taking that public health approach. We can help prevent pharmaceutical pollution. And wouldn't it be great if the molecules that were designed were actually benign by design, so that they did their job in our body, and when they left the human or animal body, they were benign and they didn't harm the environment. But that's going to take decades. Green chemistry is difficult. It's a long process. So we could also think about the marketing authorizations and making those data requirements much stronger, thinking about not just the single drug that gets authorized, but thinking about the cocktail of medicines in which it might have a place. Production, making sure that factories across the world have got good manufacturing processes and aren't polluting the water around them. And post-authorization, thinking about health technology assessments, NICE and SMC. At the minute, we think about clinical and cost effectiveness, so let's bring environmental impact into that. And again, in our formulary changes, could we prescribe drugs that do just as good a job for our patients, but actually are better for the environment? And when patients have finished with their drugs, making sure that they take them back to the right place to dispose of them. And ultimately, if every organisation could be a good water steward, we'd be well on the way to reducing pollution if we did all of these things. So one of the first things that we did in Highland was to become indeed a better water steward. And we worked at Caithness Hospital right up in the north of our patch, and we were successful in becoming the first hospital in the world and the first public agency in the world to actually be accredited for the Alliance for Water Stewardship standard. And if you haven't heard of it, it's a bit like being fair trade, but for water instead. Because, you know, we use a lot of water in the NHS, and we have a social responsibility to make sure that the water we put back into the system is as good as the water that we had coming into the system. As part of our work for this standard accreditation, we actually conducted a baseline assessment of pharmaceuticals that were coming in and out of our hospital and in and out of our local wastewater treatment plant as well. We looked for 8 pharmaceuticals and we found 7 of them. And it won't come as any surprise that they're exactly the same classes that Austerbeek and Boxall and Wilkinson were finding: painkillers, antidepressants, and antibiotics. So this piece of work actually led us to our next piece of research, where we commissioned CREW, which is the Centre for Expertise for Waters in Scotland, to establish a baseline of all the research that had been done in Scotland over a 5-year period. So we gathered data on 60 medicines that had been studied, and it's given us a really good picture of which medicines have been detected, where they're at, and in what concentrations. But the research has also thrown up some gaps for us in terms of compounds that haven't been studied and water matrices that haven't been analysed. But out of this initial research, we've actually established that 9 of the medicines that were studied right now might be posing an environmental risk in Scotland in our waters. So we've now got a database with over 3,000 data points. And again, this is a UK first. It's been published, it's publicly available, and you're very welcome to go and have a look at it. But you might be more interested in the next piece of work, because that database of 3,000 data points, we actually transferred that CREW research into SEPA's Spotfire tool, which is a GIS mapping resource, a geographical information system resource. And what that does, what a GIS resource does, is actually turn data into pictures. So we've populated it with the monitoring of pharmaceuticals, but we've also populated it with our national prescribing data for those 60 compounds that we found. And we think that this is a world first, that no other country has put national prescribing data along with national monitoring data. So that's brilliant. We have published that again. It's available, and I've put the link in the very last slide for you. So do feel free to interrogate it and see what it does in your area. We can interrogate the data by water matrix, and we can also interrogate it by healthcare facility as well. These screens are quite hard for you to see on your laptop, probably, but they'll give you what I hope is some idea of the art of the possible. So this slide, you can see the sample location is NHS Lothian, and we can filter that down on the left-hand side by wastewater influent or effluent or surface water or drainage operational area. But we can also look by therapeutic group. And for this, I've selected clarithromycin, which is one of the pharmaceuticals of concern in the water monitoring field. And you can see here the levels that are being found at what time and in what concentrations across NHS Lothian. And the dotted line in the middle on the right hand of the screen there is what we call a PNEC, so the predicted no effect concentration. So all the little triangles that are below that line are at that concentration. We don't think they're having an effect, but all the ones that are above the line could potentially be having an effect on the environment. So they're at levels above the safe level. And this is our GP screen. So here you can see that we have zoned in our GP practices and also zoned in on the pharmaceutical monitoring where those GP practices are. And again, you can see levels there of clarithromycin prescribing. So it's very early days. We don't know the full capacity of this tool yet, but we will be working through it in the months to come. And we've already got lots of interest from researchers. And indeed, we will be using it in some formulary research that we're just about to start with as well. And as part of the One Health Breakthrough Partnership's vision, that non-toxic environment, we can actually achieve that relatively easily with social prescribing. And most people have actually heard of green prescribing. And I know in NHS Tayside, you've got your Green Health Partnership going on. But actually, this is about blue prescribing. So that's water, and thinking about the health benefits, especially the mental health benefits that people get from being out in nature near water, whether that's walking along a beach, walking beside a river, or wild swimming, or out on their paddle boards. So blue and green prescribing is actually part of eco-directed prescribing, but so is making better formulary choices, greener choices in our formulary. And Jules and his colleagues and myself have actually done a review of some of the challenges, the barriers to eco-directed prescribing in Scotland. And you can see the four main themes there, that we have limited strategies about prescribing information. We have a lack of coordination across the nation. We have low stakeholder knowledge, whether that's prescribers or patients, about the environmental impacts of medicines. And we also have limitations on the environmental monitoring of all of the pharmaceuticals that we would be using. So more work is continuing on that. Another early piece of work that we did was to develop a 2-minute consumer information video on AMR. We had 5 key aims: letting the public know how antibiotics work, actually, when you need them and when you don't, understanding AMR and understanding the environmental aspect of that, educating people about how to take their courses, how to finish them, and ultimately how to dispose of them if they have any left. We did a pre and post evaluation, and we looked at educational and behavioural impact. And this is the educational slide, and you can see some quite dramatic results there that, you know, after watching the video, we've now got 100% of the audience being aware that AMR is a problem, 100% aware that the environment issue is a problem as well, almost 100% saying that they would now finish their course of antibiotics as was prescribed, and fewer people, you know, about half the people that used to share their antibiotics now saying that they would continue to do that. And this video is available on the web free of charge. So if you've got a GP waiting room television and you want to show this to your patients, please feel free to upload it. So what do we already know? Well, drugs are expensive and they're very difficult to remove from our wastewater. They're highly bioactive. We've got that cocktail. We're speeding up ocean acidification, and we're adding costs to society and to public organisations at a time when all of us, whether in our personal or our work lives, are very much cash strapped. But what don't we know yet? Well, we know that we have this cocktail of medicines in our water matrices, but we don't know how they are all interacting and how they're interacting with those other toxic chemicals that I talked about, whether that's microplastics or things like PFAS, fire retardants. And will daily exposure to those, whether you're swimming or whether you're drinking water in some countries, will they have an effect on human health? So how do they all interact, and just how long are they going to last in our environment? But I would suggest that we have got enough evidence to act, and that's indeed what we have been doing for the last 4 years in the partnership. We've been taking that pragmatic, integrated approach. We've been working upstream, and we can all start to do that to reduce pharmaceutical pollution and consumption. We can encourage good waste disposal, because after all, you know, whatever is good for the planet is also good for our patients and our public. And we know that healthy people, healthy patients, are actually low carbon patients and low pollution patients as well. So I'd like to turn now and ask you to think about your pharmaceutical footprint. So whether that's in your home, your personal, your family, or your professional pharmaceutical footprint, what size is your shoe size at the minute in terms of pharmaceutical pollution? what's your prescribing looking like? Is the medicine that you prescribe absolutely always necessary? We know that, for instance, recent evidence has said that 10% of primary care prescribing is over-prescribing. So are the medicines absolutely necessary? Are you prescribing at the lowest effective dose? Could you be giving a blue or a green social prescribing alternative, even if it's a trial to see how the patient gets on? Could you be implementing a deferred prescription? So for instance, in people with depression, could you be referring them to online CBT, which the evidence says is actually just as effective as antidepressants? And we know that antidepressants take between 6 and 8 weeks to really kick in and have their full effect. So the CBT courses could actually be finished within that time and the patient could be feeling a lot better. So you could defer a prescription and say, do this course, do this online course, and if you're not feeling better, then come back and we'll think about putting you on antidepressants. So are the medicines that you're prescribing having the clinical outcome that you're expecting? And if not, are you prescribing more medicines to try and get that clinical outcome? Have you asked the patient about adherence? Because as I said, we know that 50% of drugs aren't actually taken, that people don't adhere to their pharmaceutical regimens. So all things to start thinking about in your personal and your professional practice. And of course, we do have realistic medicine in Scotland to help us. And the principles behind that are really helpful. We try to reduce harm and waste. And when we're talking about waste in healthcare, we're not just assessing what gets thrown away, so the medicines that get flushed down the loo or put in bins, but we're talking about any intervention that doesn't actually add value for the patient. Can we manage that risk better? Are we discussing in shared decision making with our patients about the risks and benefits of medicines? Because we know that there are as many risks associated with pharmaceuticals as there are benefits. And then if we're viewing this, working in Wales, we've got prudent healthcare in Wales, pretty much the same principles, and also choosing wisely from the Academy of Medical Royal Colleges, which has the same principles running throughout it. And of course, we can think about the acronym BRAN to help us make those decisions. What are the benefits? What are the risks? And what are the alternatives? Is there something else I could do instead of prescribing a medicine? And actually, what will happen if we do nothing for the patient? And I know I may be teaching many of you to suck eggs here, and that this is your daily life, but quite often it's useful just to bring these things to the forefront of our brains again, and think about what we might do better on a daily basis. So I hope that's given you some top tips about how you can go away in your practice, because no matter what your role in healthcare, every single role is a climate role, so we can all do something. But if you're in a role that's prescribing medicines, using medicines, I think we can think at every stage. That's the really useful thing to do. So think of before prescribing, what are the patient's desired outcomes? Don't just jump to prescribe thinking that that's what a patient wants, because quite often it's not. And we've heard from Doug Danforth in the BMA that starting medicines is actually like the bliss of marriage, but stopping them is like the agony of a divorce. And we know once we start prescribing that we tend to add drugs in and we get into that polypharmacy cycle. And before we know it, people are on 10, 15, 20 drugs, depending on their age. We know that by the time someone gets to 85, that the average number of drugs they take daily is roughly 20. And when you're prescribing, think about that as well. So going back to that deferred prescription, or if you do prescribe, make sure you plan a review in and you just give a starter amount. Don't automatically give a 2-month supply, because we know that most adverse events, most side effects occur early on in taking medicines. And think after you prescribe as well. So get that review booked in, and think about adherence. Be brave and ask the patient if they're actually taking the medicines that you're prescribing for them. And yet you can make a real difference in doing all of those things, because this slide, it really brings it home for me. This is one deceased patient's returned medicines. So it's really horrific, isn't it, to see about 20 Ventolin stroke salbutamol inhalers on the table, 20, 25 packets of diuretics sitting there, painkillers, heart medicines. And one wonders if the patient had actually taken any of these, would they still be alive? But the point I'm trying to make here is, let's not get it to this stage where people aren't taking their medicine. Because remember, most of the medicines that we use, we are bringing across the ocean from low, middle income countries. And that incurs pollution in the ships that come across. It occurs pollution in the factories that make them. And it incurs carbon emissions as well. So if we could save taking these drugs, because the most environmentally friendly drug is the one that's not taken, the one that's not required. So if we could save waste like this, we could be making a really big impact into chemical pollution and into carbon emissions as well. So I'd like to finish right now with a quote from Sir David Attenborough. He has been instrumental in educating the masses about our natural world. And he said that the truth is, our natural world is changing, and we are totally dependent on it. It provides our food, our water, and our air, and it's the most precious thing that we have, and we need to defend it. And remember also that he said that the plankton are the lungs of our world. So I'd like to thank you for listening today. I hope I've inspired you to think about your own personal practice. And I'm leaving you with this list of resources. If you want to learn more, if I've whetted your appetite, there's plenty more to find here. And my presentation will be shared after the session. So thank you very much indeed.
Thanks very much, Sharon. That was really fascinating stuff. I should have realized Nemo is a saltwater fish rather than rivers, but you did come back to rivers, so
absolutely,
I wasn't completely off the reservation there. There were some really very interesting things, and certainly in keeping with the sustainability, environmental impact chats that we've had in numerous grand rounds over the last couple of years, thanks to our collaboration with Munro, who I don't even know if he's in the audience today or not, and with Leslie Crichton, who have been really helpful in bringing these kinds of talks to grand rounds and to the whole audience. So does anybody in the audience have any questions or comments they'd like to make? Feel free to put your hand up or stick it in the chat if you are a bit shy. The photo I have of like your photo of the person who died with all inhalers is a patient with cystic fibrosis who similarly died and then emptied their kidneys. And I apologize for my sneezing colleague in the room. It's something going around. And that there was huge. That's like boxes of IV antibiotics and inhalers and nebulizers and all sorts of things. And it's not uncommon, I think, to find these cupboards. In your picture, there were large amounts of inhalers. And as a chest doctor, that's one of the things I'm really working at is the environmental impact of inhalers is huge, 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 huge. And not all inhalers are the same. But salbutamol in the form of Ventolin, as you described there, is by far the biggest impact in terms of global warming potential and greenhouse gases and carbon footprint, because it's not a great inhaler. It's 30, 40 years old. There are better versions, but it's just what everyone uses. Everyone knows it's Ventolin, so everyone just reflexively prescribes Ventolin. And we've also shot ourselves in the foot a bit here, because we for years have said you must prescribe inhalers by not generically, but by their trade names, because that reduces the chance that you get a slightly different formulation. So people still prescribe Ventolin, not so much in Tayside, but around the country they definitely do. And we need to get away from using Ventolin and use other things which are the same drug with a better footprint. And that is in our local guidance here in Tayside and spreading out to the rest of Scotland. Of course, the best way to reduce the salbutamol use is to control your disease better, so you never need to use it.
Yeah.
And I think you touched on that. So Kirstine Hill, I think that's Kirstine, who's one of our antimicrobial pharmacists and works with us in the chronic infection team, says we'll certainly look at using the NHSH video re-AMR during World Antibiotic Awareness Week. And she says that she retweeted it last year, so she's on board already. And we do try to do an antimicrobial World Antibiotic Awareness Week grand round. I'm not sure when that week is, Kirstine, but I'm looking at you see if you want to give a talk.
Yes, it's normally in November, Tom, so that's when we actually launched the
I've got
video.
plenty of empty slots in November, so if Kirsty
Yeah.
want to knock up a talk for me, that'd be fantastic.
Yeah, and just going back to your inhaler there, if no one's got any questions at the minute.
Please.
Yes, salbutamol, of all inhaler use, salbutamol contributes 70% carbon footprint of all inhalers. And we know we use far too many of them. And patients that are getting more than 3 a year are actually at bigger risk of morbidity and mortality and having exacerbations. So that's not good. We need to get patients actually using their steroid inhalers, because a lot of people actually think it's the blue one that helps them the most. So lots to do there. But yeah, you're right about the Ventolin and the branded prescribing. In Highland, we've just changed our formulary to more environmentally friendly inhalers. We're now advocating the prescribing of DPIs first versus an MDI. A monitored dose inhaler is the one that has all the greenhouse gases in it, hydrofluorocarbons that hang around in our atmosphere for thousands of years. And the DPIs are the dry powder ones, so they don't have any propellants in them. And we're advocating now the use of Easy Breathe, I think it is. There's a lot of work being done at Scottish government level as well. The climate change and sustainability strategy was just published in August, and the 3 things that are priorities there are inhalational anesthetic gases, reducing the use of desflurane and nitrous oxide, inhalers, changing from MDIs to DPIs, because in the UK, I think we're sitting about probably 90% MDI use, whereas in countries like Scandinavia, it can be as low as 10 or 30% of the proportion of inhalers. So we've got a lot of work to do there. But there's lots of work coming very soon on that. We've got a respiratory prescribing strategy being launched later at the end of the year, and we'll also have work from the Climate Change Board coming. So you should see things changing quite rapidly, Tom.
Let's hope so, because I may have a hand in the respiratory prescribing strategy, so I'm glad you mentioned it. Amy Rogers has said, has telehealth, remote healthcare had any impact on prescribing patterns? i.e., are we reducing the carbon footprint from travel, but increasing pharmaceutical footprint?
Yes, that's a good point, Amy. We certainly are reducing the carbon footprint. And I think the last evidence that I saw from the Near Me evaluation was that we'd saved something like 1 million patient miles during COVID. I haven't got any evidence to say that we're actually increasing pharmaceutical footprint, that we're getting more prescriptions. So I can't comment on that, but that would certainly be something that would be very interesting to look into. So I'll get back to my telehealth people and see if they are thinking about that, and if not, that they could.
It's certainly an interesting question, Amy, and I think there is a degree of robbing Peter to pay Paul in a lot of the things we're trying to do. So, for example, virtual capacity, which one of the Scottish Government, it was interface care and it's called virtual capacity, is to look at the increased use of OPAT, so out of hospital prescribing of parenteral antibiotics, to save bed days. And it does save bed days, and you can give people IV antibiotics at home, but then you tie people into IV antibiotics for a big chunk of time, which has plastic and increase manufacturing costs and the sharps bins. And this might seem a little like I'm picking at hairs here, but actually when you multiply that up, that's actually large amounts of things. Whereas in hospital, it may be that after improvement, you come off the IV antibiotics after 2-3 days, and then a suitable oral is found, and that's a less impactful thing. So there is a degree of that I think needs teased out, and that's why we have people like you, Sharon, who know this inside out and are doing the work to make sure that we're not cutting our noses off to spite our faces.
Yeah, and I think there's a real lack of data around this, Tom, that we have. We haven't got the end-to-end picture of the carbon footprint of a process, and neither have we got the end-to-end data around pharmaceutical load and pharmaceutical pollution as well. So that's something we've just been working, actually, Royal Pharmaceutical Society, RCGP and the Academy in developing a statement about climate change and sustainable medicines use that some of you may have seen in being tweeted and in the press recently. And there are 6 things there. And one of those is to work with the Association of British Pharmaceutical Industries to see how we can improve the data that we have, and so that we don't make change, because it's inevitable, isn't it, that we're going to make a change based on the evidence that we have right now. And in a few years' time, we're going to get more data that says, no, we should reverse that change. But we've got to do what we can right now with the data that we have.
One final question before we sign off and get to our afternoon activities. This is from Alison Dicker. She says, should prescribed medicines come with an environmental and cost impact statement?
Yeah, I think they should. Something happens at the minute, Alison, called an environmental risk assessment. So when a manufacturer makes a drug, they conduct this ERA. In my opinion, it's got holes in it. It's only for the single drug, not for that cocktail of interactions that I described. And it goes to the MHRA or the EMA, the licensing agencies, but it doesn't actually, it gets looked at, but it doesn't get factored into the decision. So we know that 20% of the medicines that are licensed actually have got an adverse environmental impact. But we're still using them. We're still bringing them through health technology assessment. Some work that I'm just about to start in Highland, I've been successful in getting an MRC bid, trying to develop a decision framework so that our formularies actually start to take clinical cost effectiveness, safety, as well as that environmental impact. And in future years, that carbon impact as well, so that if you as a prescriber could actually look at the BNF, you could actually see all of that information. And if you looked at your local formulary, you would have some traffic light system, whether it was red, amber, green, or 109876, to tell you just how good a pharmaceutical was in the round for the patient and for the planet.
Excellent. Right, it's 2 minutes to 2. So before we all turn into pumpkins, let's thank Sharon for a really excellent talk. She said to me beforehand that she was worried that she wouldn't make through the whole talk with her croaky voice. And it worked for Ted Lowe with the snooker commentary for 40 years, so it certainly worked for you today for an hour. So thank you very much. I hope your sore throat improves. And to everybody else, thanks for coming. This will go on to YouTube once I've had time to edit it. Next week is Craig Mowat, who's going to talk about fecal hemoglobin testing in the quest to reduce colorectal cancer rates here in Scotland and further abroad. And then there are gaps. So if you're sat there on a talk, an idea, a quality improvement project, an audit, you have some interesting cases that you'd like to go through, or you have a student or a friend who'd like to give a talk, then please get in touch. I can give you a slot. And let's fill up your own rounds. Thanks very much again, Sharon. Thanks to everyone, and I'll see you again next week.